It's a pleasure for me to finish off this lunch symposium by telling you a little bit about our experience in Basel. So I'm the head of the molecular assay development team at the Institute of Medical Genetics and Pathology in Basel, Switzerland. And we have recently introduced tumor mutational burden in our routine. And I want to tell you a little bit about our experience, how we went on with this, and also what are the next steps in terms of biomarkers in immuno-oncology. What are we looking at next? So before we go into the biomarkers, I just want to give you a very quick overview of the tumor-immune interaction. So as you all know, the cancer cells within the tumor tissue are embedded in a very complex microenvironment. Now, if cancer cells die, they release antigens and neoantigens that can then be presented by antigen-presenting cells to naive T cells, which will be primed, activated, and they may undergo clonal expansion and re-infiltrate the tumor tissue, where they will then recognize these antigens on the surface of the cancer cells and destroy them. So that's the way of how the immune system is fighting cancer. What we also know is that cancer cells have evolved mechanisms to avoid this immune reaction. And we all know that one of these mechanisms is, for example, by expressing so-called immune checkpoint proteins, such as PD-L1, which then interacts with PD-1 on the T cells, essentially inhibiting their anti-cancer or activity in general. So these immune checkpoint proteins are in fact the targets of immuno-oncology therapy drugs, as we all know. For example, PD-L1 inhibitors, PD-1 inhibitors. So what they do is they basically block these immune checkpoint proteins and reactivate and enable the T cells again to be active and fight the cancer cells. So we know that some patients react very well to these therapies, but in fact, the vast majority of unselected patient cohorts show very little to no response. So it is important, in fact, to identify these subpopulations of patients that will respond to immune checkpoint inhibitor therapy. And most commonly now used, most widely in practice, is very simple immunohistochemical staining for PD-L1, which has shown to some degree allow the selection of potential responders. But we also know that the predictive power is still very limited. So there's still a need for more effective biomarkers. In recent years, I'm sure you're all aware, tumor mutational burden has been heavily discussed in the field as a potential biomarker. So, of course, we were also interested in this. We are working in the routine laboratory and we're doing next generation sequencing. It's part of our routine. So of course we are interested also, can we implement this in our routine? So very quickly, tumor mutational burden is nothing else than counting the total number of somatic mutations in a cancer genome. And the assumption here is that the more mutations a cancer cell has, the more likely it is to actually express and present neoantigens that can then be recognized by the T cells, which then renders these patients more likely to respond to immune checkpoint inhibitors. This hypothesis has been demonstrated to be partially true or to be true in several clinical trials where tumor mutational burden was assessed either by whole exome sequencing or also by targeted next generation sequencing panels. So looking at this data, again, we were very interested in introducing this into our clinical routine. So what we did is to test whether this association of TMB with therapy outcome was also true really with everyday samples in a routine setting. We took a cohort of 76 non-small cell lung cancer patients that had all received immune checkpoint inhibitor therapy. And we had full clinical follow-up data of this cohort, so we knew which patients responded and which did not. So we went back to the archive and collected biopsies from these patients prior to treatment. We then extracted DNA and we assessed the tumor mutational burden status by using the Thermo Fisher Oncomine tumor mutational load panel. The reason why we use this is because we are already running other Oncomine panels in our workflow. We're very happy with them, and this is very easy to just integrate into the same workflows that we have already set up. So the panels covers a total of around 1.2 megabases of coding regions distributed over 409 cancer genes. It requires very little input, which is also important for us because sometimes we have very little biopsies and we want to have as low as possible rejection rate. And most importantly, it comes with a full automated analysis software, which is important, especially in a routine clinical setting, to not need to have a bioinformatician setting up a pipeline for every single panel that we are running. So we sequenced our samples to a sequencing depth of roughly 1000x, and for TMB calculation, the algorithm here uses all non-synonymous single nucleotide variants as well as indels. So the first thing we noticed when we looked at the data was that we had some samples that had extremely high number of mutations, and we quickly noticed that this is very likely to be caused by fixation artifacts due to cytosine deamination. So what we did is we went back to the samples, we reanalyzed them, we treated these samples with an enzyme called UDG. Now this enzyme selectively digests nucleic acids that contain deaminated cytosines, which are essentially uracils. So by treating the DNA prior to library prep, we could in fact reduce the number of artifacts very significantly, allowing us to lower our rejection rate and really be able to rescue these samples. So from this, actually, we decided now also in routine that we treat all our samples with UDG before we go into library prep for TMB for this assay. So then we went on, we analyzed our 76 samples, and the distribution of TMB is shown here, ranging from 0 to roughly 23 mutations per megabase. Of course, cutoffs are important. The big question for TMB. First, what we did is very simple. We simply divided the entire cohort into tertiles. So we have the lowest third ranging from 0 to 4, then the intermediate third of the samples 4 to 9, and then basically everything at 9 or above would be considered as TMB high. Later on, we also confirmed this with doing a ROC analysis and doing the Udens index method in order to calculate the optimal cutoff, which was essentially also then 9. So now the main question was, does it correlate with clinical response? And what you see here in green are all the patients that showed a durable clinical benefit. This we defined as having at least 6 months of progression-free survival after start of immunotherapy. And what you can see here is that indeed there is a statistically significant association with higher tumor mutational load and associated with positive or durable clinical benefit. We next ask, well, is there a difference, if we subset this group, is there a difference between patients that had stable disease and those that had either complete or partial remission? Well, as you can see here, there was not really a difference between those. The main difference was really between the ones that had no durable clinical benefit. Now, if we apply our cutoff of greater or equal to 9 mutations per megabase, we can see here that indeed this TMB high subgroup shows the highest proportion of patients having a durable clinical benefit, while in fact for low or intermediate we didn't really see a difference. Next, we look at progression-free survival, and the same is here. If we look at TMB high versus low and intermediate, which we put here together, because also here in fact we don't really see a difference between low and intermediate TMB. But we do see a very significant difference between TMB high patients and everything below TMB of 9. The same is also true for overall survival. Now, we saw that, okay, there is an association, but there was still this cloud in the middle. So our question now was, well, how does it compare to the current standard, which is PD-L1 staining? So what we did first is we simply we looked for a correlation between tumor mutational burden and PD-L1. So we simply have here on the x-axis TMB and on the y-axis PD-L1 staining. But as you can immediately spot, there is not really any correlation, neither for the patients with benefit nor those without benefit. So from this we asked, well, maybe they act complementary together. So what we did was we looked at the double positives here on the far right, as well as the double negatives. So TMB high, PD-L1 positive, and what we can see actually now that we enrich even more for patients that did have durable clinical benefit, while also on the other end, we reduced the false classification rate at that end as well. Really telling us that maybe it's a complementary approach that is ideal for patient selection. We confirmed this also by doing a ROC analysis where we looked at TMB alone versus PD-L1 alone, and then the two combined in a very simple linear model. And you can also see here that there's a slight increase in the predictive power when we combine the two. So we were happy with the results, and we were so happy that we have now introduced TMB into our routine. And while we are happy, we are still not quite satisfied, in fact, with these results, because we still have quite a lot of misclassification. So from this, and now I get to the second part of my talk here, from this we actually went back to this scheme and we asked, well, what other potential biomarkers can we look at? And what I will show you today is very preliminary data, but also very promising data, looking at moving away from the cancer cells, but actually starting to look at the T cells. And more specifically, we look at the T cell receptor beta chain using the recently launched Oncomine TCR beta assay, which is also in one of the two versions is compatible with our FFPE blocks that we used to assess TMB. So we again went to the same cohort, and from the same material we now extracted RNA, and essentially what we look at is the diversity region, which tells us something about the antigen specificity. But now we look at two very specific metrics that we get out of this data generated by this analysis. Again, it's an NGS panel, so we get sequencing data. Now, first metric is so-called TCR convergence. Now, what is TCR convergence? Very simply illustrated here. Here you see 3 clones, T-cell clones. If you look at the CDR3 amino acid sequence, they are identical. So actually based on this, we would say this is one clone. These are not three clones. We cannot distinguish the 3 clones. But now, because we're actually doing DNA or RNA sequencing, we also get the nucleotide information, the underlying. And now if we look here more closely, we do see slight differences. And in fact, this tells us that these are 3 different clones that, even though they have the same amino acid sequence, they use different codons. So we can say there are 3 different clones that all converge towards the same antigen. So independently, they expanded within the T cell population to converge towards the same antigen. So this is the first metric. The second metric is so-called TCR evenness. Very simply explained, if we have a population of T cell clones, if they are all equally represented in the population, we have an evenness of 1. Now, if we start to have one clone overrepresented because it undergoes clonal expansion, we have an uneven distribution, so therefore our evenness would be decreased. So now, keeping this in mind, what we did so far is I show you here a subset of 37 samples, so it's a low cohort, so keep this in mind, it's preliminary data. But already here, now if we look at this TCR convergence frequency per sample, we see already an association and a significant difference between patients with no clinical benefit and those with durable clinical benefit. Indicating that those patients where we have several clones having the same specificity towards one antigen are more likely to respond to therapy. The same is true for evenness, where lower evenness is associated with durable clinical benefit. Indicating here that if we have an environment permissive for clonal expansion within a tumor, those patients are also more likely to respond to immunotherapy. Now, if we compare this to TMB and PD-L1 of the same subset here, we can see that in fact this performs very similar, if not better, than TMB and both TMB and PD-L1. Now, if we look a little bit more detail, again, convergence versus TMB. So here on the x-axis, we have TMB, mutations per megabase. On the y-axis, this convergence score. The dashed lines indicate here the TMB cutoff at 9. So now, if we look at this subset, we look at TMB, everything here in the yellow box would be considered as TMB high. And we do catch some of the responders here shown in red, but we actually miss quite a few. Now, if we add the convergence frequency, which also we calculated the cutoff again based on the Udens index, and we, in addition, use this, we actually catch 5 more responders that are missed by TMB. Nevertheless, TMB also includes 1 responder that is missed by convergence. So again, indicating a complementary setting here. Now, what about evenness? So how does evenness compare to convergence? So now here we compared the two. On the x-axis, we look at evenness, y-axis, convergence. Again, if we look at convergence only, those are the patients that we would consider based on the calculated cutoff as potential responders. Again, we do catch most of the responders. And now if we add evenness, so everything below that cutoff, we do catch additional 2 responders. Of course, keep in mind, we also include now non-responders, so this has to be kept in mind. So basically, evenness identifies an additional 2 responders, while convergence identifies 1 responder as missed by evenness. So based on this, we said, what if we combine those evenness and convergence into 1 TCR score? So we did a logistic regression model, which now yields us a score including both values. Again, we calculated the cutoff based on a Udens index method, and it does perform slightly better than either convergence or evenness alone. Again, if we compare it to TMB, where those are the ones that we identify. Now, if we look at this TCR score, we actually identify everything that is identified by TMB, but TMB, in addition, includes those 2 non-responders. So actually, the performance here is better than what we see for TMB. Again, very preliminary data, a small cohort, but it looks promising enough to us to move on, to expand the cohort, to start to look also into blood, instead of just in tissue, having matched tissue and blood to really get a comprehensive view of how this can help and maybe become, again, a potential biomarker for immuno-oncology. So with this, I would like to conclude and just quickly summarize what I've shown you. First, the tumor mutational load assay is easy to integrate into a routine laboratory, especially if you're already running the Ion Torrent workflow. Importantly, here are the pre-analytics, so the UDG treatment that we only specifically for this assay introduce for all the samples that we test now in order to reduce the artifacts that we may otherwise overestimate the TMB. Our study shows that TMB correlates both with increased progression-free survival as well as overall survival, but we saw that the predictive power is still not there where we would like to have it, and that's why we started to look at TCR repertoire, where we have very promising results and show at least the similar power as TMB. So in my opinion and our opinion, at our institute, likely a multi-biomarker approach is going to be the most feasible solution for immuno-oncology patient selection. So with this, I would like to thank everybody involved, especially also Thermo Fisher, Timothy Looney, who unfortunately is not here today, but he helped us a lot in analyzing the data, and of course, everybody else that was involved, and you for your attention. Thank you.